Hello, I'm Dr. Deepak Bhatt for ACC.org. We're here at TCT. Well, I'm actually not at TCT, but Dr. Moran is, and I think Dr. Vetrovic is.
I am.
Oh, terrific. So I'm lucky to be with both of them. They're sort of right there out in the field, like real reporters covering what's going on. And we're here to discuss what happened at TCT on day one. It's our day one wrap up. And let's start off with the FAME3 trial. A lot of discussion here about FAME3. Maybe I'll start off with Dr. Moran, since she's one of the directors here of TCT. This was a big trial, not just for today, I think for the whole meeting. What did you think about it?
I think it's a brilliant study, one we've been waiting for. So this was a one-to-one randomized clinical trial of FFR-guided PCI versus angiographically guided CABG in patients with three-vessel disease. I think a really important study, but the trial did not meet its primary endpoint. The primary endpoint was non-inferiority of PCI to CABG in terms of the major adverse cardiovascular and cerebrovascular events, which included death, MI, CVA, and repeat revasc. And it actually showed a significantly higher event rates in the PCI arm, mostly driven by revascularizations, but also the other endpoints looked in the wrong direction for PCI. So I was, a bit surprised. Obviously, it's a one-year endpoint. There were about 30% diabetic patients with multivessel disease, where we do know that these patients don't do as well with PCI compared to CABG. I don't know how much that contributed. I'm very intrigued by this study.
Yeah, though the 1 year aspect, if anything, one might expect the data to tilt even more in favor of CABG with longer term follow-up. So I don't know, George, was there rioting on the streets at TCT? What did the interventionalists do when they saw these data? It looks pretty good for CABG and multivessel disease, if you ask me.
Yeah, interventionists are always feel wounded. A couple of points that I would make that what was a little surprising to me, because I thought this was in a way playing off of syntax too, or could be interpreted in that light, with maybe less interventions, less stents, which would only for the important lesions would cut down on some of the complications. And it kind of didn't happen. So I thought that was an interesting part. Second thing is, the one thing I would say that is in favor of PCI here is that the non-ischemic complications, major bleeding, arrhythmia, acute kidney injury, were higher in the CABG group. So it's not a home run by any stretch for intervention, and it's probably dissuades intervention, certainly in the diabetics and complicated cases.
Yeah, I think that's a good interpretation. Well, speaking of FFR, IFR Sweetheart was presented here, the 5-year results. The initial results were published in New England Journal. Actually, I happened to write the editorial for it, sort of giving a big thumbs up for IFR. What do the 5-year results tell us? Roxanne, let's start with your impression of these data.
I just love the work by the Sweetheart group. Here's over 2,000 patients enrolled. Now we have 5-year results, and basically IFR and FFR did literally on top of each other in terms of the expected outcomes for the primary endpoint out to 5 years. Very, very similar. IFR about 21%, FFR 20%. The hazard ratio was just about 1.09. So, I think there was no difference in the composite outcomes. So to me, it seems like, dealer's choice, IFR, FFR. And I think if you give interventionalists the choice, I think they might go with IFR.
George, is there any good reason to do FFR instead of IFR if you've decided to do invasive assessments of lesions?
No, and I think the helpful part of this is because IFR is just better tolerated by patients. I think this is an encouraging finding that'll allow people to do what they'd like to do without kind of some of the other not complications, but at least discomfort for patients and so forth. So I think this is very favorable and helpful.
Yeah, I agree with both of you. The final trial we're going to cover today is the Radiance Hypertension Trio trial. This is a trial of renal denervation. It's a sham-controlled trial, so very well designed. Roxana, what did you think of the results of this study?
So, this was sort of a later follow-up. As you know, the Radiance Trio study was already presented. The 2-month data was presented. This is a sham-controlled trial on top of medical management of these patients. This was a really well-conducted study. And the blinded comparison was already done at 2 months, showing a benefit, perhaps with the patients at 2 months with the renal denervation. And this is basically looking at the assessment from 2 to 6 months and seeing how the patients did in terms of blood pressure control, et cetera. It's a small study, 120 or so patients randomized, really well conducted though. The classes of antihypertensive medicines were well evaluated. These patients for the most part were on 2 to 3 meds. And at 6 months, the magnitude of the reduction of blood pressure was no different. There was no statistical significant difference between the two arms. But what was interesting, I think there was some reduction in aldosterone antagonist use at 6 months in the renal denervation arm. So interesting to just kind of look at that data a little bit more and perhaps think down the line that it could be an interesting hypothesis to kind of take on in a much larger clinical study. To me, it's a hypothesis generating study that perhaps opens the window for renal denervation again. I don't know, or maybe Dr. Vetrovec could give us some comments on what he thinks, but that was my view of it.
Yeah, I think that's a really balanced interpretation of it. Certainly encouraging, but no clear difference at the end of the titration of blood pressure medicines in terms of the blood pressure itself. George, what do you think of these results, and what are the next steps? Do you agree with Roxana? More?
Yes, I think Roxana hit a lot of nails on the head, but the couple of things. Yeah, she does. The important thing here, I think, is that we tend to put patients in trials that follow the rules. And there are a lot of patients we take care of that don't follow the rules. And I think it's hard to design a trial to deal with the realities, the people that don't take medicines and so forth. So I don't think anybody's trying to sell, or I wouldn't try to sell this as a substitute for medications. But for the patient who's not complying, some blood pressure control is better than none. And ideally, maybe one drug rather than 3 drugs could be sold easier, less side effects or so forth. So I think there's hope here. It needs a lot more data, bigger trial, and we need long-term data on renal denervation. I still am not comfortable what the blood pressure is in a few years, and that's an important part of this.
No, I agree with you. We've got to make sure we set the bar, sort of higher than maybe the minimal regulatory bar, because without long-term data, I'm not sure, what we've really got here. But nevertheless, I would congratulate these investigators on a really well-designed trial. It's tough to do these trials. I mean, I know from personal experience, and it's even tougher to make them positive, but the data are what they are. Well, at any rate, great speaking with the two of you. I really look forward to talking to you again tomorrow. And to the crew out there watching us, enjoy TCT.